Yes, welcome to this next session, one of the last sessions, I think, for today. Yes, sorry we started a couple of minutes too late. That was because of the previous session finalizing a bit too late. But this session is going to be about getting the full potential of the supra-annular Evolute FX Plus valve in a changing landscape. So I have the honor to do this together with Dave Smith, Catherine Klein, and Andreas Hruk. So yeah, we have the slides up there. So we have, of course, some session objectives in this 1 hour session. So we want to learn, or that you can learn something about commissural alignment, the importance of it, how to achieve it with this platform, and how to get easier coronary access. And that gets more and more important the more we go into younger patients. Also, another objective is to learn about TAVI considerations when treating patients with a small aortic annulus or surgical aortic valve prosthesis with a small true inner diameter. That's all about optimizing hemodynamics, of course. And then last but not least, I would say if you go into the younger patients, we want to be able to have a proper treatment of our bicuspid patients. As you know, in the guidelines, European guidelines have pushed the age to 70 years of age with the assumption that it's tricuspid cases. However, that doesn't mean we cannot treat bicuspid patients with TAVI. In my own center last year, we treated almost 100 bicuspid patients with TAVI. So it's definitely doable with good outcomes, but you have to know how to do it, which prosthesis, which to use, which are the advantages from one and the other prosthesis. So with no further ado, I think I'm gonna invite first Catherine, yes?
Yes.
You're gonna give you this. And you're going to talk about the commissural alignment and coronary access.
Yes, absolutely. Yep. Thank you very much. I'm happy and a little bit excited to start the session with you. And I want to introduce you to a very nice and old lady from our center in Germany. She is 76 years old. She has a severe aortic stenosis. And she also had a coronary artery disease with a closed right coronary artery and a left coronary artery, which was already stenosed. So we knew we had to go somewhere to this artery. So I want to invite you to go through our planning for this patient with me. Think about if you would have done something else. We are very keen to hear your opinions and encourage you to step in if you have questions or any remarks. We went through the heart team, obviously, and we decided for TAVR. And the next steps will be planning for her future coronary access. We know we have to get there. We want to go through the step-by-step commissural alignment. Spoiler alert, we will do it with an Evolute FX Pro Plus, and we will do troubleshooting, what if it doesn't work. So we start with the access of this patient. She had a quite nice aorta, a little bit calcifications, but no stenosis, no kinking, and not something very interesting to worry for. But when we zoomed in, we already saw a little bit narrow anatomy. We saw a narrow calcified STJ and SOV and a calcified valve. So we thought about, okay, what to do, and went for a Tremenger report. You see the annulus dimension is nearly in the middle of an FX26. We got an SOV we already knew would be a little bit narrow. It's on the edge to a chimney anatomy with the right with 26.8 and the left with 27. And when we went to the STJ, we saw it is a little bit low with 15 millimeters, and it's really, really narrow and calcified. We had a STJ with 20 millimeters, and we also had a low LCA, which we wanted to protect so badly. So in our center, we have a team which measures these CTs, and when we have like red flags, you already see them, we write in the group and say, okay, be careful, there are some problems with this patient. And she already got 4 of these red flags in this measurement of the CT scan. So our implant strategy. We wanted to go for an Evolute FX Plus 26, obviously, because we wanted to have all the advantages of the supra-annular design. We've discussed,
Catherine, before you continue on this, maybe we can interrogate and ask the audience what would they do because this is indeed a difficult anatomy if you take the coronaries into consideration. What would be their choice or what considerations would they make? Anybody who wants to?
I can go back to the measurements so you can.
Yes, show this, and then maybe anybody or otherwise we will pick anybody. Yes? Anybody who wants to comment on it? You. What would you do?
He was sleeping.
He looks very happy.
What would you do? What would be your considerations for valve choice?
First of all, I would check if the coronary arteries are symmetrical, because if I have to implant a 26 FX plus, I have to check first of all if the coronary artery are at 120 degrees.
In the center of the cusp, you mean?
Yes, because in that case I have to sacrifice, in most of cases, the right coronary artery in order to privilege the left coronary artery in the most of cases.
But that's all in the assumption now already that you're going to do an Evolut FX. Would that be also your choice? You would think of other valves, other considerations you make?
I think that in this case, also a balloon expandable device could be okay for this case, honestly.
Well, does everybody agree on that? Would people go for a balloon expandable in this case? Which talks against that?
I will be happier using the balloon expandable because she's 76 and life expectancy now not more than 10 years in my country. So, and I want her to exit the room safely. I don't want to block the arteries. I think I can accept the gradient about less than 20, 15 is fine. So if she would be my patient, I would go for the balloon expandable.
Balloon expandable?
I absolutely get this point. Oh.
Yeah.
And we also discussed it, and even if we are strongly believe in the supra-annular design, we also were a little bit frightened that if we end up with a balloon expandable valve a little bit too high, we will get in this STJ here with this 20 millimeters with a 23 balloon at least. It was so calcified that we really were afraid that we can burst it up, and this was also one reason why we did not want to go for a balloon expandable.
Yeah, the STJ doesn't look very inviting for a balloon expandable. Then indeed you have your hemodynamics results as well. I mean, 76, this patient in Europe, I mean, could still live for maybe 10 or 15 years as well. So
30 years.
Yeah, so I mean, going in there with a sapien, what sapien would we take from a size? I mean, you can almost not go for 23, 20, or, I mean, so I think it's fair to go for self-expanding, and then you have to make your considerations what you're going to do there, yes? I think if you're really open to talk about which choice, then you have, in Europe at least, either Evolut or Navitor. Evolut has the advantage that it has that waist in a way with the stent frame, yes. So that's a great thing that I'm pretty sure the coronary would not occlude. With the Navitor, I would be more concerned that it's a more tubular stent frame. It will push the leaflets more on the side. You cannot do a commissural alignment with that prosthesis that easily, so that's negatives on that. So you have to balance all these pros and cons from the different platforms. Yes, but you can continue, yes?
So after we balanced, like you said, and decided for the Evolut, we also wanted to take into considerations all the questions you had, how to implant it the best possible way for this patient. So there are two things we thought about. First thing was the depth. Because as you see, when we go for best practice would be 3 millimeters. I try to enhance the gold markers in the bottom. They show the 3 millimeter point. When we would go a little bit more high or low, we want to go for 5 millimeters, as you see it here, because then we will end up with the window when we align fine right in front of the coronary artery, and we also will be with the skirt below the coronary artery. When we go up like this, it's a little bit extreme, but this should simulate a position like on the 0 point. We would end up with the skirt in front of the coronary artery. Perhaps we will not have a sinus sequestration, okay, because there's enough space, but not much, but probably enough. But all the alignment would not bring anything because we would not get the window in front of the coronary artery. So our implantation depth goal would be 5 millimeters. And we really want to focus on commissural alignment in this patient. Yes. So we have a window in front of the right coronary artery and in front of the left coronary artery for her, and not commissure. And for the next steps, I just want to out myself. We started with commissural alignment right up front, and it worked so well that personally I never tried to understand why it works so well. So I started to try to understand why it works so well for this presentation, and I want to take you with me. This is her valve. We made a photograph of her. You see the gold marker on the bottom and the 3 millimeter point, and you see here the C-tab. The C-tab is always oriented. You see there's only one tab with C on the upper part. Is always oriented with a commissure. And always oriented with the gold markers. Gold markers means commissure. Next to it, around about 60 degrees, are the windows. So how does this help you? The valve is not put like you want to in this loader, but it is always done the same way. The C-tab is always up. And as you see, there are some head markers. You don't see them with your eye, but you see them very, very good on the fluoroscopy, and I enhanced them for you. The head markers always put the same way, so we always know how this valve is crimped in this loader and in the capsule. And when we go now for the implantation, the first step we want to do is we want to go for 3 o'clock with the flush port. Because we know when we go for 3 o'clock, like you see it in the video, we always end up very good aligned, like in over 90%. So this is the first step you want to do before you even start to do a fluoroscopy. Then we do it in our center. We go to an LAA view. It's the recommended way. I don't know if you all do it, that you go to the LAA view. But the advantages this view has is you open up your arch. So you have the view if the valve is going nicely through the arches, if you get stuck anywhere. And you also will see the head marker on the outer curve. And as you see here, it makes a difference how much LAU you go. There is not a designated angle you have to go, but at least I think 30 would be good to open up the arch very good and to see the whole dimension of the arch. I don't know, do you go to 30 or where do you go?
Yeah, typically to some kind of 30 LAO indeed, just enough to open up the arch, but it's true, it's patient dependent of course, yes, how much you go. But that's not really patient specific angles. We go roughly LAO 30 and get the marker on the outside. You can maybe continue and we can maybe also draw that in the same time.
So you draw and I continue with the next
continue.
fluoroscopy picture. So you see now we are reaching the arch. And when you reach the descendants, you see she has much calcification in the fluoroscopy, more than we thought in the CT scan. And you also see, I enhanced it for you, that when we turn the handle a little bit, the head marker is turning to the outer curve. You don't have to turn much. The handle and the capsule react very, very good. So you do small movements and you want to get your head marker to the outer curve. So this is your next step in your step-by-step check. You go for the outer curve in the LAO view.
Yeah,
is it what you wanted to draw?
Yeah, so you have it better there.
I don't know, I like yours.
No, it's better like this, so indeed. But in fact, it's true that the flush port is normally 3 o'clock, so pointing away from you. To be honest, doing a lot of cases, typically in majority of cases, you have to do a counterclock compensation. It's almost 2 o'clock introduction in real world practice, but okay. And then you look at this in the LAO view. I agree on that, yeah.
So when we have our outer curve marker, a head marker, we go to the next step, which would be to go forward with the valve. And when you take your focus on the head marker on the left part of the video, you see that the head marker really stays in the outer curve. And if you now focus on the hand of the second implanter in the video, you see that he's holding his hand like this. He's not holding the handle. When we remember, we really try to let the handle go freely over the arch, because then you do not build up tension, and you see the head marker stays on the outer curve anyways, and this is where you want to have it when you reach the annulus. You want to have it on the outer curve, like Ole is drawing it there.
Yes, while you propagate over that arch, you want to see that marker, that head marker actually, or Mexican head, you want to keep it on the outer curvature. In some rare cases indeed, if you see it flipping while you're crossing in that LAO, if you see it flipping to the inner side, then it's better not to go all the way over the arch. You can stop right in the middle, pull it back, and do a compensation turn. Yes, that's typically the best. In that way, you avoid crossing a couple of times over, in and out the arch. And that's never a good thing because you increase your stroke risk passing the aortic arch. So that's basically the only thing you have to do. Yeah, I agree.
So we have our head marker near the annulus in the outer curve, check. And now we want to go into our implantation view, which for us would be a cusp overlap view. We're always implanting cusp overlap. And when you see this animation, you see that with the moving of the aortic root, also the head marker moves. It does not stay in the outer curve, but it moves to a position we call center front. We see it in the middle of this position when we go to cusp overlap, and this is the next checkpoint. You want to make sure you see that your head marker in cusp overlap is in the center front position, so you can move on. And in our case, it looked like this. Could have been like 1 millimeter more, but it's perfectly fine in this position, center front. So we wanted to go from there to do the implantation. Bless you. So we opened the valve, we aimed for the 5 millimeter mark, and we're quite happy with this depth. And now you can see very, very nicely the gold markers when the valve is opened. And you remember the gold markers, they each stand for one commissure. So when we hold it, and you see this is our cusp overlap view, and the gold markers here are in a 2-to-1 position, and you imagine the annulus like this, because the right and the left are aligned. This is cusp overlap, the non-coronary cusp stands alone. These gold markers who stand for a commissure will go very nicely with the native commissures, and you have a perfectly aligned valve which is not lying with the commissures in front of our coronaries. So check, we have a cusp overlap view opened and we have a 2-to-1 situation. So, not to spoil, before we see the last result, what do you do? Ola already mentioned it, when you really have not the head marker in the outer curvature, but in the inner curvature, or when you see a misalignment when you open the valve. It's what you already said. The solution would be to withdraw the system and rotate in the descending aorta. And this is to avoid tension. You don't want to turn against resistance, you don't want to turn in the ascendance or even in the annulus to create no tension, which will be going very unpredicted when you release the valve. But I'm sure every one of you has a patient in mind where you were just happy to get the valve in the annulus and would never ever retrieve it because so much kinking, because the patient is not stable. Perhaps you have a 90-year-old lady with a high calcification and stroke risk, but no coronary artery disease. This is very individual. But for this patient, I think when we would have ended up misaligned, I think we would have retrieved it.
Yeah, especially the concern here in this patient, I mean, she's relatively young still. I mean, let's say, yeah, 76. Especially the problem is always coronary access, also in redo TAVI, if you have a narrow ST junction. That's the biggest red flag you can see. Yeah, so a narrow STJ, low STJ, that's really a problem. And I think in these cases, I would probably, if I would end up being commissural misaligned, I would do an effort to pull it back and re-rotate. And again, not in every case, but in this case, probably yes. And she's borderline also at risk of, for coronary disease. So, but okay, you did very well. Yes, you respected all this with the marker on the outside. You checked, you had your markers correct. The 2-1 pattern, yes, and then you did great there, yes. So.
Yeah, I think we did very great. You see the result? No, obviously I brought a case where it worked very well, but this is like 99% of the cases work very, very well, and you have some patients which are difficult, but then worked very good, and she had a perfectly aligned valve. And a little bit of regurgitation. I think the height is also like we planned to, but now we want to see what we all wanted to know, no pressure. How long did it take to cannulate? You see here, it is real time, first attempt. And you see it's under 10 seconds for the left coronary artery, and also for the right coronary artery, you see it's also under 10 seconds, and it really was easy to go for them because of the big windows which were right in front of the coronary arteries. So let's wrap up our 4 points to get a good commissural alignment. In 99.9% of the cases, you go with a 3 o'clock flushbird. You go for your LAA view and go to the outer curve with the head marker. Then you change to cusp overlap and be center front. And last but not least, you have a 2-to-1 orientation of the valve when opening it. And then I'm happy to take your questions if there are any left.
Oh, great.
Front row, please.
We have the box there.
Somewhere.
Yeah, you can throw.
There we go.
The question is that should we protect the left main before the deploying the valve?
I think in this case, it was not necessary because the leaflets were not that heavily calcified, they were not long. It was a little bit of chimney anatomy, but at least we had 27 in the SOV, so I don't think it would have been necessary. And the protection for the left main, if you do it with a chimney stenting, we have the problem we want to go on this left main again, and then you have this chimney stent in the left main if she has a problem in 5 years. So this would have, for me, this would have been against the protection.
I would probably also not have done it in this case, but on the other hand, look, if you're more in valve scenarios and you really doubt, the rule is if you really doubt, put some safety. It's better safe than sorry. I mean, that's probably the best way to do. Very often you don't need it, but at least you're protected. Yes, it's very hard if you have an occlusion then to go in there and try to make it open. Yeah. But another important point was these 13 millimeters of skirt. It's a thing you have to take into consideration. For example, I was recently doing a valve in valve. Yes, we had a clear preference to put the evolute in the surgical prosthesis, but then, and there was clearly some risk of coronary, if you do all the efforts to do basilica or whatever you do, unicorn, or there was a basilica we were doing in that case. Well, if you implant very high, yeah, then the whole skirt, you can make your V in the leaflet of the surgical prosthesis, but then if you implant your evolute extremely high at 0, yeah, your skirt of the evolute is 13 millimeters. Then all your work you did for your basilica doesn't pay off. Yes, so it's an important thing which you emphasized in the beginning. You have to think of these 13 millimeter skirt, and then you can taper your height. Also here for your coronary, that's what you were doing. You didn't want to end up at 1 or 2 millimeter. You wanted to more 3, 4, 5,
yeah,
and you
5.
probably ended up 3, 4. So that's great. Then you can do the reverse calculation. If you do the commissural alignment correct and you implant at 4 millimeter, then at least the coronary was around 9, 10 millimeters. So that's perfect. The bottom of the window, the big window, just ended right in front at the same level as your coronary. So you have to think of multiple things, the rotation, but also the depth and the skirt you have in the evolute. Yes?
I think there was another question.
Yeah. Can you elaborate a little more about troubleshooting if you cannot get the commissural alignment while you are in the annulus? Why you cannot do just minor corrections on one hand, and on the other hand, if you pull it back, which way do you have to turn it?
Yeah. You want to comment on that?
We have made not that good experiences in turning it in the arch and in the annulus because it seems that the system gets some tension and then the valve doesn't deploy as controlled as it would be when you go normally without turning it in the arch. When you pull it back to the descendants, it would be the same steps all over again, but perhaps to correct it, like Ole said, to like 2 o'clock, not 3 o'clock, and also try to go with the head marker in the outer curve. And perhaps then you can try to hold it while pushing it forward, and what Ole suggested to a little bit control it under angulation and under fluoroscopy to try to go in the outer curve when you end up not aligned.
So I can add on that I mean, if you really want, you can kind of turn while the system is over. You can make small corrections. I've done that. It's against the IFU, so you're doing stuff which is not officially approved, but it's doable. Another thing is, I had a case in the summer. I know it was a young guy, bicuspid. He had aberrant origin of the coronaries, both coming from very close to the commissural between the right and the non-cusp. I don't know if you have the time, but I can do very quickly, like if you have the 3 cusps here. Yes, this is the non-coronary cusp, yes. This is the right, and this is the left cusp. So he did not have a left main, actually. He had 2 coronaries. It was a bicuspid case, and he had his 2 coronaries coming from pretty close from this commissure here, and then it was a bicuspid type 1. Yes, it was such a case. Well, what you can do reverse thinking, and then in fact what I wanted is, in this young patient, which was end of the 60s, I wanted to have the big window just here in front of this aberrant origin, this big 1 ostium. And you can do that. Yes, you can calculate an angle on your fluoro, like then it was probably a little bit of LAO I was taking here. You're looking from here then. So you can calculate, this is AP, yes, this is REO, this is LAO, so you can calculate the angle you want. And in that angle, I wanted to see actually 2 posts of the 2 gold markers I wanted to see there, yes, on that side of the screen, on the left side of the screen. How do you do that? That's of course the reverse as normal, so I wanted also to do the reverse to cross the arch. Normally that's not advised, but what you can do is you can use a long dry seal sheet. Then in such a case, you have a long sheet, 65 centimeter sheet over the arch. I did the reverse torquing with the marker on the inside crossing the arch, and I actually arrived well. Even if I wouldn't have arrived well, I shouldn't have been able to, shouldn't be scared of pulling it back over the arch and crossing again, because you do it protected within a sheet. Yes, so if you have a case where you think it's super important, you obtain Commissural alignment, this is a way to do it. Then you can use such a long dry seal sheet, go in there, you can very protect it, you can do 2-3 times correction as needed, and even in very difficult, weird anatomies, you can correct for it and get still the big window here in front of this ostium. Yeah, so there's a lot possible, and we managed to do it, and we also managed to cannulate the coronary just like you did. Yes. Okay, I think we have to move on for the program, because I mean we started a little bit over time. So thank you, Catherine, for that. Maybe small applause.
Thank you.
And then. Now it's Dave. Yes, you put yourself in pole position for the next.
I have.
Yeah,
Yes,
good.
yes. Hi,
Okay,
everybody.
Dave, go ahead.
Okay, I've got a few questions for you in this presentation as we go. It's not a particularly complicated case, but it does raise some interesting issues, decision making as you go. Okay, so firstly, 61. Relatively small, BMI low. Immediately we're out of our comfort zone because there's some gobbledygook about congenital stuff, double-chambered right ventricle. Fortunately, they haven't really had to do anything specifically about that. She had endocarditis 25 years ago, which was medically treated. And later, she had a 23 millimeter perimount with VST closure in St. Thomas's. So now we're 13 years later, she's had a stroke, thought to be atheroembolic, and a further stroke. So now that she's symptomatic, she's got progressive shortness of breath. Of course, we have to try and work out what we're going to need to do. In this image, you can see she has good left ventricular function. The double outlet right ventricle is not a problem. The pulmonary flow velocities are fine. On this picture, I can't make the pointer work, sorry, but let's go back, sorry. On this picture, the things to point out particularly really is the flow velocity, so 5 meters per second, so unequivocally severe aortic stenosis with very fibrous restenosis, which is of course characteristic in restenosis of a surgical prosthesis. So then we have a heart team discussion, which is a bit higher risk for surgery, smallish, annulus maybe, degree of physical frailty, some mobility impairment. So hands up, I mean, you probably haven't got many surgeons here, have we? But hands up for repeat surgery.
How old was the
I
patient
thought
again?
61.
61.
I must say, I kind of thought they bailed out a little on this case. Everybody else happy with transcatheter, yeah?
Say again, what was there a gradient initially after the implantation? Is there PPM in play here? No? Was good after surgery?
Yeah, she was fine after surgery. We don't have the echoes from
I know the
surgery.
surgical threshold for a good valve are a little bit different than ours, but still, it was good.
Yes, I mean, as far as we know, it was done in a different hospital, who knows exactly, but certainly no suggestion of her having had to be followed up with failure of resolution of symptoms.
Okay.
Okay, so I mean, one of the things that was relevant here probably is she's relatively young, and people all think, 70, 75, 65, whatever your cutoff is. But personally, I always think that's wrong. It's not to do with what age you are, it's to do with what your anticipated longevity is. It doesn't matter if you're 60 or 50, if you're only going to live another 6 years. And of course, you're going to have a transcatheter valve. So in her case, mentally, the anticipated longevity, given her various conditions, was probably around 10 years. So we thought it was probably reasonable. The surgeons weren't very keen. Okay, fine, we will consider taking this on. So here's the CT scan, and you can watch this go several times. You can see we have, sorry, the pointer's not working, but you can see we have plenty of room in the sinuses. So firstly, there's no fear of coronary occlusion. Sizing, it's a 23 paramount, so we got about 22.5. So really, technically, there's nothing particularly unusual about this case, but there are a few points to discuss. Firstly, what valve to implant? Okay, so I'm going to force you to get active here. Hands up for a balloon expandable valve. Come on, keep going, keep going. There's a few hands up for a self-expanding valve.
Yeah.
Yes, you've all come to the right session. I mean, I think the data for self-expanding valves in this setting is extremely strong, isn't it? You know, you get a lower gradient, you get a better valve area, you'll almost certainly get better longevity. So, you know, it's pretty robust. Although, as you may know, there's a randomized trial going on in these patients as well. So what valve to implant? Here's an interesting one. It's not specifically related to the valve exactly, but whether to fracture the surgical ring or not. So hands up for considering fracturing. And is that relative? Just do you anybody want to comment on that? I mean, are most people saying no because of the risk or because it's big enough already? Anybody want to comment? Do you want to comment?
What's the true inner diameter? Remember us of this valve. True inner diameter?
It's a 23 magna E, so it's 22.
21 it is.
21
max.
Well, but on the CT it came out as...
Yeah, but 21.
She was really small, right? She was like...
She is small, yes.
Small.
And the initial, like, I'm coming back now, I'm repeating myself,
Yes,
but the initial
that's
gradient
good.
we assume was good.
We did assume it was good.
So we always take that into account.
Yes.
So,
Yeah.
and
But at the same time-
honestly, we think that we, with a supra-annular valve, achieve a gradient without fracturing that's actually
Yes.
better than the surgical gradient,
Yes.
usually.
But at the same time, we can't stop thinking, she's only 61, she's only 61. You know, we need to get the best we can.
I will base my decision on the gradient post-implantation,
Yeah.
whether to fracture it
Yes.
or not.
But that's
We'll
very
come
often
back to
really
that.
bad guidance. I mean, invasive
Yes.
gradients, like...
Yeah, I mean, it's quite hard to get really good, reliable invasive gradients. You have to have a pigtail really absolutely either side, and you're still interfering
We
slightly.
saw this morning, there was a live case from Vigo, Spain. It was a TAF in TAF. It was a Evolute in a Sapien. After the implant, they were like, yeah, it looks pretty well. And then invasive gradient, 2 millimeters mercury. They did an echo, 3.1 meter per second.
That's so typical.
That just shows,
Wow.
I mean,
Yeah,
invasive
yeah.
gradients is really worth nothing,
Yeah,
to be honest.
yeah.
And so that's difficult to judge, I would say.
Yeah. No, I agree with that.
But okay.
So the other thing, and it plays to your point, is if we are going to fracture the valve, at which stage do you do it? Do you do it before you put the valve in, or do you put it afterwards? Are the risks greater afterwards or before? It's probably not a discussion specifically for this forum exactly, but you can argue the case
But it's
either
an
way.
important point because if you look, it's sometimes depending on, you can look in your app, yes, your valve and valve app, and if you sometimes doubting between Evolute 23, 26, and you think you want to fracture afterwards, you have to really think of if you put a 23 in, the waist of a 23 Evolute is 20. If you would go there with a non-compliant 22 to do your fracture, you may at the same time tear your leaflets. Yes, so it's super
absolutely.
important. I'm also a big fan of using the Evolute platform for valve and valve because you have the supra-annular benefit of that valve. But if you want to fracture or post-del, be aware that you have to take that waste into account. Yes?
Yeah. I mean, personally, not to give it away, I think it's really much more sensible if you can to fracture first, then you know exactly what you're dealing with and what valve to implant. And some of the risks that are inherent in fracturing after, such as annular rupture, coronary occlusion, embolization of the valve, damage to your new valve, etc. Some of those risks are diminished by dealing with it first. Yes, you could say, but don't you rather destroy the valve and end up with severe AR? Yeah, but you've got your new valve right here, ready. It's good, ready to go in. Anyway, it's an interesting discussion. And around that, of course, exactly as Ulla just said, so what size are we going to put in? At the moment, it's sized for a 26 because it's 22. But if we fracture it, will it actually be a 29? Or
Yeah,
will it
because
still
that's the
be a
thing, if you would have to
26?
fracture this valve through in a diameter, you say it's 21?
It's almost 2 millimeters down on the
Yeah,
paramount.
so then to fracture this, you should at least use a 23 through balloon. Then you should
Probably 24 even, yeah.
Yeah, but then you should put it to AVLU 29 because the max balloon is 23 then.
I know.
Ah, good. They're
I
going to
know.
be arguing about what we did now. That's good.
No, it's
Excellent. Lastly, unfashionably, cerebral protection. So actually this lady has a lot of the risks. She has previous stroke, she has valve and valve, the most sort of weak indicators, and we can't help thinking she's only 61. So, we don't use it, but very occasionally we do use it.
Yeah, sure.
Yeah. Okay. Anyway, so this is what we did. So right radial, left radial, right femoral. We put the sentinel in. We thought, okay, this is an indication. She's had previous strokes and she's young. Aligned the valve nicely. You can see there's plenty of room in the sinuses, and the valve looks a tiny bit small, doesn't it? To be honest, in the capacity of the anatomy there. We fractured up front. So we did take a 24 true. We went up to 16 atmospheres. At that point, the dial dropped abruptly to about 12. We knew that we'd fractured it. You can't really see it that well. I think it's hiding behind one of the sternal sutures. It's not the most obvious fracture you've ever seen. And now the question is, okay, we were doing that. Which size valve are you going to put in? You're going to put in a 26 or a 29? Hands up for a 26. Okay. Hands up for a 29. Okay. Yeah. Okay. Well, we put in a 26. The reason we did really was we thought the fracture was only going to be really very small. You don't. Unless it was obviously destroyed, the extent to which you expand the valve is quite limited. And what you really want, you don't want your valve to be constrained unduly. You get the best hemodynamics out of the valve when it's not too much oversized for the ring that you're putting it in. This is a very solid ring. It's not a fibrous annulus. This is a ring. So anyway, we chose to put in the 26 to have it as close to fully expanded as possible. Slow implantation.
Beautiful.
Nice position. It very commonly looks like this. You get a fabulous seal without any regurgitation, without any gradient of note, and the hemodynamics for what they're worth. The invasive gradient was nothing, but it wasn't measured, with extreme precision. And actually, the mean gradient on echo was only 4. So that's really good. I don't know if that's partly because we fractured or not, but that's obviously going to stand her theoretically in really good stead. She might get 15 years out of this valve. Certainly, there's every chance that it's going to be the only repeat intervention she's going to need. Mm-hmm. So I think for us that demonstrates, if you like, the versatility and flexibility of this platform in a valve-in-valve small annular setting.
Yeah. No, absolutely. I fully agree. It was a very well executed, well thought case up front, well pre-planned. So indeed, I think one of the other benefits, indeed, if you were thinking of this surgical valve. Oh, sorry, I don't have a thing here. Yeah. If you have that surgical valve, let's say you have these posts here. Well, if you put a balloon expandable valve in there, well, first one concern is, of course, the gradient there and also under expansion of this valve. But the other thing I'm concerned about is and there's data about it. So you make your neoskirt here because the surgical leaflet will make a neoskirt here on the side. And then you put in your balloon expandable. You can already see, and this is then the aortic root here further down, your washout on these leaflets is much less. Yeah, so there is reports that indeed there is a lot of leaflet thrombosis on valve-in-valve of balloon expandable in surgical prosthesis. The benefit of putting a valve in where the leaflets are higher, sitting right here, you have really good washout here still, yes? So there's better expansion of that valve. So there is clearly much less leaflet thrombosis. The HALT, yes, the hypoattenuating leaflet thrombosis risk is clearly much lower if you go for this supra-annular leaflet position valve instead of an intra-annular leaflet position valve for revalving TAVI and SAF. Yeah, so these are also concerns I take, and this is a patient with multiple strokes in her prehistory.
Yeah.
So I mean, maybe it's not, but I mean, you want to avoid some leaflet thrombosis in that particular patient, I would think.
Absolutely, definitely. And I mean, we wouldn't consider putting a different type of valve into this sort of patient.
Mm-hmm.
But when did you decide if it will be a 26 or a 29? Did you decide after the dilatation or before?
No, because we had to have it ready first. And I thought the chances of us actually really expanding it beyond, I mean, it was 22, maybe we would make it 23. It's still going to be good. We want, sometimes when you put do a valve in valve, if you think, to give myself a margin of error, I'm going to just put the bigger one in, then the whole thing gets a bit crowded. It doesn't fully expand. You don't really get the benefit. Whereas when you do really get the benefit is if you have it only just enough oversized that it will fit nicely in the neo-annulus. Yeah.
Okay, thank you, Dave. I think we are already a couple of minutes behind schedule, but if there are any questions, please post them here so we can see them. We can take them in the discussion further, or raise your hand. We're happy to take any question, of course. But I think we have to move on, Andreas, now. Yeah. Thanks, Dave. So, Andreas, you're going to talk about an important topic, of course. It's about TAVI and bicuspid.
Yes, thank you for the invitation. I was asked also to touch briefly on the literature, what it tells us about bicuspid aortic stenosis in general, and maybe in particular for a self-expanding platform. These are my conflicts. So looking at the landscape of bicuspids, what we usually talk about, 90% of the cases we see are type 1 bicuspids. Most commonly, as you see here, marked in green with the rough between the right and left. As you can see, there is a big variability between patients. These are 8 quite recent patients we have treated. You can have a raphe that's calcified and long. You can have a raphe that's calcified and short. You can have a non-calcified raphe, long or short. You can have kind of a bridge, like in the upper right one. And occasionally you have a fusion on the other side. I didn't show any type 0 here. So they can be very different from one patient to the other. And obviously that might be then a different choice of what you do, which prosthesis, which balloon strategy you use, for example. This study is quite well cited. It came out 5 years ago. It's a big 1,000 patient registry with the main message. It's a deadly combo if you have excessive calcification and calcified raphe. Just point to that this central illustration, the data is completely unadjusted between the groups. So probably there are other differences as well. We can also say that 72% of the patients were treated with balloon expandable sapien, so maybe this is not true for all TAVI that is done in bicuspids. I would also say that the curves, as you see, they continued to diverge out until 2 years. That's probably not due to bad procedure that has caused any side effects for the patients that you would see a bit earlier. So I'm a little bit questioning the narrative of the deadly bicuspids for TAVI, that all of them should go to surgery. But I think we need more studies on it. Speaking about studies, Ole and this group in the Nordic collaboration, the Notion 2 study, recently published a 3-year follow-up. And as you know, in this study, in total, there were 100 bicuspid patients. 49 of them got a TAVI valve. 73% of those were evolute self-expanding. And actually, correct me if I'm wrong, but after 3 years, there's not any more a significant signal that it's worse with TAVI than surgery for bicuspid patients. Mm-hmm. Is that right?
Correct.
So it actually, the scare of bicuspids comes from relatively few bad outcomes, we would say. So I'm a little bit questioning if it's so bad to treat bicuspids with TAVI, but we can come back to that. So I have one specific case. I will go over some details and then we can discuss what to do and how to do it. Really elderly male, 87 years of age, he has COPD, he has a quite bad kidney function with GFR of 32. Only he has dyspnea, he has an aortic stenosis that's not super severe, but it's severe. Maybe a bit underestimated. As you know, in bicuspids, often the jet goes a bit diagonal. Maybe you don't capture the max gradient with a Doppler. Mean gradient 38, DVI 0.24, normal LVEF, and on the coronary angiogram, no stenosis. CT looks quite ugly. Bicuspid type 1A, raphe length 13, so qualifying as a long raphe. If we go back to that registry, we see there on the second last line, aortic valve calcium 7,300, so clearly highly calcified. Annulus, normal size for a male, 25.1. If we do the normal annular diameter measurement, if we, for example, measure the intercommissural distance, it's a little bit more, 25.8. And there's also, in addition to that, severe subannular calcium, as you see in the lower left.
Andreas, this patient, of course, in his anatomy falls into that category that you were just saying.
Yeah, the red line.
The red zone, yes. It's excessively calcified. It's a long calcified TAVI. I don't know how old was the patient?
87.
Okay, fair enough. I mean, I'm not going to open.
And bad kidneys.
Yeah. So that's TAVI, no, without a doubt. Even everything above 75. But if this
I have these pictures too, just to show the anatomy with the moving image, VR reconstruction. And you see, and there's actually subannular calcium on 2 sides out of 3. Horizontal aorta a little bit, 71 degrees, bicuspid type 1A. So,
did you think about not doing it at all?
That's the question. Futile, tell him, you're old and frail, go home and enjoy life as long as you can. Option 1. Maybe we can have a vote on those.
Yes.
Number 2, looks scary, but it should be done. Take a holiday and let your colleague do it. 2. Option 3, make it circular, squeeze it out with a balloon expandable. It's clearly doable. You will get the valve in, but is the risk too high? Maybe for aortic root injury. Or number 4, then respect anatomy, use a self-expanding TAVI. Might get a little bit underexpanded maybe in this anatomy, but the data studies show us you will have a low gradient and lower risk of aortic root injury.
We can ask by hand raising, yes, the 4 options.
What were the comorbidities? Was he frail? Was he...
Kidney function was bad,
but
and COPD.
As a human being, like mobility, frailty?
Mobility was quite good, but eGFR 32 and COPD in 87 years. So that's a hard no on surgery, I guess.
Oh, no, I'm just choosing between futility and TAVI.
Okay.
Yeah.
He's still walking around, unsupported.
Okay.
Let's ask the audience. Who would think in his center this patient would be too fertile, the fertility would be too high, you would deny him actually treatment? Who would do that?
One brave person.
Only one brave person indeed. Yeah. Because sometimes it's the best decision too.
Yeah, definitely. And I would as well if he was a bit frailer, like as a human being. But if he's robust and he's fully ambulant and everything, it's tricky.
Yeah.
Second option.
Was that? Oh yes, no, definitely that.
Okay. Now we know who the cowards are here. Yeah. Okay.
Number 3, balloon expandable.
Hang on. There's a question.
Over the microphone.
I think the reality is that anatomy is very high risk, and this is probably someone where you have to be very pragmatic with your patient. That we're thinking about the risk of annular rupture is super high, but also the risk of a suboptimal result is also significantly high. And I think for me, if I saw this sort of patient, I'd probably kind of put it to the patient as well as to what they want.
Yeah.
Because I don't think it's.
I think here it should be absolutely key that you inform this patient correctly about the risks there are. Stroke risk, moderate PVL risk, maybe worse risk. And I mean, that's really patients.
And I must say, what I tend to do here is I really exaggerate the risks. I'm not sure if that's exactly correct, but you know how patients don't necessarily understand the numbers? For some people, 1% sounds a lot, and for others, it's nothing. And so I try and say, you've got a significant chance of having a stroke, a significant chance, and if I think they'll understand the numbers, I'll give the numbers, but I'll exaggerate them. So that if they really come to it, you say 20% stroke, 20% death, whatever, so they've really got to make a positive decision that I understand that, but I'm so limited, I'm prepared to take those risks.
So coming back to Ola, this kind of a patient, would he also be in the Notion 2 study, or was that outside the scope of the study?
No, look, I mean, that's unfortunate. In the Notion 2, there was no screening committee. So there was just a site assessment whether the patient could be in, yes or no. So there were definitely anatomies in which maybe many people wouldn't treat with TAVI, indeed. That's okay. It was an all-comers bicuspid. I think in reality you have to be selective. Yes, we do tons of bicuspids, but sometimes there are bicuspids where we say no. I mean, if this would be a 71, 72-year-old, below 75-year-old patient, I would probably try to push it to surgery first.
Yes,
honestly.
of course, obviously, yeah. But it's a sponsored session, but you can still vote for the number 3. Is anybody voting for number 3, balloon expandable?
Nobody. They don't dare to. Yeah.
No, that is a terrible.
Okay, then option 4 seems to be the majority. It's my
But honestly, yeah, what is talking against the balloon expandable? You had a lot of calcium in the LVOT there. You had an extremely long calcified trachea. Of course, this is a case at risk of some aortic root injury, annulus rupture, all these kind of complications, bad complications.
But even if you don't go for the balloon expandable, if you end up with a self-expandable, like crimped and crumbled like this, you have to post-dilate it. So perhaps you at least have to think about which balloon you want to use to dilate.
But you can do that more controlled, more careful in a way, yes? I mean, you can go with sub-dimensioned balloons and...
Yeah, and I think, post-dilatation is more dangerous than pre-dilatation. And quite often in this anatomy, people won't pre-dilate much because of the anatomy, but then find they have to post-dilate strongly, and actually that's more dangerous. So, I mean, I'd be prepared to pre-dilate this reasonably aggressively in order to avoid having to post-dilate.
Yeah. Okay, next question. And which size pre-dil balloon?
Then we have to see
Annulus
the CT
is
again.
25.
Show the CT again, maybe?
Yeah. And the intercommissural distance is 25.8.
22.
22?
22.
No, I want to get more than that. I mean, probably 24. I mean, I don't want to have to post-dilate this.
23 or so, yeah.
24, 23, 22. Okay.
We're very...
There's another...
Okay.
More numbers are available.
I can give you the mic.
It's also even non-compliant, semi-compliant balloon. But let's continue because we have only 10 minutes left.
Okay.
Oh, there's a comment, yes?
One comment.
Sorry, I'm just trying to take one step back, but in our center, we would have done FEOPS analysis for this one.
Yeah, you could.
Because often with FEOPS, because the LVOT calcium is from 4 to half 5 o'clock, there's a very high risk of PVL. And if that would have been the case, we would have gone for a supra-annular balloon expandable valve with either Edwards or my valve. Because as Dave pointed out, if you're using self-expanding, there'll be a pre-dil valve and then there'll be a post-dil most likely. So there is a risk of annular rupture even with self-expanding. And FEOPS in these kind of cases is quite helpful.
True.
I would say it's helpful, but I think the data it's validated on is quite limited so far. But yes.
And
yes.
Sorry, one other question. Did he have much AR at the outset? Because, of course, if they have no AR at the outset and you leave them with even only moderate AR, they may be physically no better at all. So that's another factor to add in.
Okay. Going on, MDT decision not operable, frailty, high age, and TAVI with self-expanding Evolute FX. Surprise in this session, I guess. Case plan. We use very few sentinels nowadays, right or wrong, but at least the orthodox way to saying is that it's not proven by studies anymore. So, had a LVBB, got a temporary pacemaker, right femoral access. We used the London DC wire 22 balloon, and we discussed an Evolute FX 29. So now we come to the implant. This is quite unremarkable, but just showing the expansion of the 22 balloon.
You went for 22? Great.
Yeah.
Good decision.
We'll see. Then I also wrote down here the angulation that we used. We try to follow these 3 gold markers and always avoid parallax. So we started then in a cusp overlap, which was only REO 5 in this case. And going on, it's quite unremarkable.
Relatively high, I guess.
Relatively high, but not super high. Yeah, starting to unsheath, nothing special happening really. The next picture, we have released 85%, but then you see 1 gold marker is far up, big parallax. But then when we corrected the parallax by going a lot LIO in this case, then we're actually sitting, surprise, quite fine, I think, with a depth of, 4. Obvious that we have a ton of calcium on the upper side of the picture. And then is it okay to release there, or should we do something else?
So who would think it's not okay to release?
And I have the last picture as well. Then we try to take another angulation.
Unless the pigtail is high there, it looks as though it is a bit low. Always when you go LAO, you get the slightly false image of being more at a nicer height here, but you know in the areocaudal that you're actually relatively lowish. It's a little critical.
I have the picture the far to the right as well, which is not REO but less LEO.
Look, it is indeed for bicuspid relatively low, although you're at 3 millimeters, and it's extremely underexpanded. So you will post-dilate, it will still foreshorten a bit there too. So I would also be scared of that.
Yeah, because should that be taken into account? We try to do that. If we expect post-til, we don't want to be super high.
What is of course important, if you have this, before you take your decision to release, you have to make 100% sure there's no infolding, because this is a very underexpanded valve. It's no problem if it's just a circular underexpansion, but if it's due to an infold that you see due to a diagonal line in the stent frame thing, then I think it's an absolute no-go for release. Yes, then you should probably recapture it, take it out, do more better pre-dilatation and go with another valve in again. But now it doesn't. There's no signs of infolding. Then it's just a circularly underexpanded valve.
It actually looks surprisingly symmetrical.
Yes.
And I think it's fine. So continue. We have 5 minutes. Yep.
Okay, it will be released. I promise. Now parallax correction again here. Since the kidney function was bad, we didn't take an extra shot here with contrast. We just thought, okay, it's in, it's good. Post-dilated with the same balloon at 22. Must admit the balloon position was not ideal, maybe.
A little slider.
But why did you decide to post-dilate? I think
we just thought it looked quite underexpanded. Then I must admit it looked almost the same after this half with the post-dilatation, must say. But
perhaps it would have been an option just to do. I know you wanted to go for no contrast, but perhaps it would have been already fine in the left picture. I'm not sure.
That's completely true.
But on the other hand, I mean, you try to avoid as good as possible major underexpansion, I think. So I think it's fair to do it here.
Here comes the orthogram.
Okay.
And the question is, do you dare to oppose that chunk of calcium, that rock on the upper side?
Who would like to do something more to that valve? Lots of experienced people shaking their heads.
No, I think this is great.
I think
Andreas.
Good enough.
You've done really well.
Good enough. And actually, it wasn't that bad.
The key thing is there's no regurgitation, so you haven't converted this guy from symptomatic due to AS, due to symptomatic due to AR into a small ventricle. So that, for me, is the key thing. Yes, it's not perfectly expanded, but you do anything more to that, you do risk annular rupture.
We actually have an echo technician in the room for our procedure, so we get good gradients from echo immediately after release.
Nice.
That's what we got mean gradient of 9. Trace
really
PVL,
good
so actually
it's a great
surprisingly
for this,
good.
87-year-old patient.
And the guy is alive also.
It's
also
always
important.
a bonus at the end of the case.
So great outcome. I think what I want to comment, and it's a little bit summarizing here also on the case that you showed for TAV in SAF or also TAV in bicuspid. I think a key aspect of this platform, that's also the title of the benefits of the supra-annular leaflet. Well, of course, we know all about the hemodynamics, but there's more than the hemodynamics. To me, what is a big benefit of this whole platform is, and I want to introduce that terminology, is the decoupling effect from this valve. So what do we mean with that, the decoupling? So the decoupling, that's the great benefit to me for working with an evolute, and I take that into my practice. If I am treating a valve in valve, a TAV in SAF, or a TAV in a severely calcified bicuspid, the good thing is, if your leaflets are supra-annular, the great thing is I don't have to be worried about under-expansion so much in that narrow surgical prosthesis or narrow calcified bicuspid leaflets. You saw even your prosthesis, you know, you use a 29, yes? It's 29 evolute, so we know that the 29 evolute, the waist is 23. In your case even, it looked a bit like this, yes? It was even a little bit less expanded. So you know that on the inflow, there was no 29 reached at all. It may be even just 22 or 21. Yeah. But the great thing is, with an evolute, even if you have no great expansion due to the anatomy, on the inflow part, you can even have less than 70% expansion there from your nominal size. We have a publication on that. The great thing is if you go to node 4, 5, and 6, where the leaflets are, you have actually 95% expansion. So that's a great thing. I think the decoupling effect of the evolute, that's one of the not very much discussed added values of having supra-annular leaflets. It's not only hemodynamics, it's also this decoupling effect. So whether you have here underexpansion with bicuspid valve due to severely bicuspid or a surgical prosthesis, you have still great expansion at your leaflet position. And due to that, you have less risk of leaflet thrombosis as well, yes? Because there are data from balloon expandable in bicuspid, those cases where they have severe underexpansion or ellipticity of, for example, a sapien, well, there's a lot of leaflet thrombosis in these leaflets, yes, on CT scans, which you don't see with evolute. So these are, for me, one of the great added values on top of the hemodynamics is the decoupling effect of this procedure. And I think you show that in your case, you showed it also in your bicuspid case. So this is something I think we should take into account as well if we take a valve choice for our specific patients. And then your case nicely demonstrated actually now with the FX plus here with the big cells in the middle. I should actually use another color almost for that. I don't know if I have that. Yes, now here with these big cells, well, we have to care less about issues with coronary access. Yes, if we do logical thinking, we see where the coronaries are, even in challenging scenarios, as you showed, we come away with it and we preserve good coronary access. So with that, I think we're also 1 minute over time in this session. I want to complete this session. I want to thank everybody to be here and to give us questions and interaction as well. Thank you.